questions from the audience. I think the first one I can probably answer is Endotool used in pregnancy and pediatric populations? And the answer is yes. Rana, are you using it in L&D at all?
Yes.
Yeah.
Yes, we are.
Yeah. Yeah, it's used, can be used basically anywhere you're going to use an insulin infusion. It's used in the operating room, and it's used in pediatric populations. The only caveat there is the patient needs to be greater than 2 years old and weigh greater than 12 kilograms. Do you have plans to use it in labor and delivery, Scott, as well?
Yeah, we are.
That's right. Yeah.
The volume is not as high as in the other general adult population, but we do use it in the OB population as well.
And the next question is forming a system glycemic management committee helpful for the implementation process? And I would, before I ask some of you to comment, I would just say that you need a system glycemic management committee is key. You bring all the disciplines together and really help elevate the priority of good glycemic management in the institution. I'll just ask each one of you. Deborah, are you aware of a glycemic management committee with UNC Health?
We don't have a direct committee, but we do have the champions from the various sites that when we implement, there are the critical parts of the decision making. So yes, each site does have that personnel that relates to glycemic management.
Yeah, excellent. Rana, I'm sure you have one. You must, if you're director of the service line, you probably.
Yeah, we do. We have our diabetes educators from all of our hospitals come together, as well as a system pharmacist. And we also work very closely with all of our quality people. So yes, it is definitely a unifying thing to really look at glycemia. And that's really helped us from a leadership standpoint get support that glycemia control is really, really important, especially with the CMS guidelines and little things they want us to abide by coming up with severe hypo and hyperglycemia. So yes.
And Melissa, as a medication safety officer, do you have that as well? And you're probably involved with that?
Yes, we do have a glycemic management committee that is relatively new, kind of came about around the same time period as our evolution with expanding Endotool. And so one of the things that we're tasked with as a committee is following the data about hypoglycemia and hyperglycemia, following all the data from Endotool, and then also helping with expansion. But anything that comes up regulatory from our Joint Commission surveys related to glycemic management is then kind of funneled to that committee so that we're in charge of, anything related to glycemic management. And it's helped a lot having that one go-to spot rather than having to touch base with endocrinology and touch base with nursing staff and touch base with our IT folks. It's good to have kind of all of those people already at the table.
Yeah, I was amazed back in the day when I started a glycemic management committee at Centera. When we began, there were so many different insulin protocols. They had names that were similar, but the protocols were completely different. And you order the ED IV insulin protocol, and the goal ranges would be different than what people thought, and it was catastrophic. And there was so much peeling back layer and layer of the onion to get where you needed to be to drive good care. Let's see, we have a couple more questions here. Is anyone aware of a protocol to wean from Endotool? To wean, I don't quite understand this question. Is there a protocol to wean? No, I can't quite understand that question, so I'm going to try to deal with that offline. And then there's the question around, we talk about the single facility implementation versus multi-facility rollouts. And just looking, I'll look to you, Scott, about strategies to keep the workflow standardized and consistent across the whole system, because everybody likes to do it their own way.
Yeah, yes, for sure. When we planned to expand our Endotool instance to the other hospitals, it did require us to take a look at the current state of our various insulin infusion power plans or order sets. And what we found was, boy, we had a lot of variation in how we were addressing insulin infusions at the different hospitals, and then came to find out that there wasn't even widespread adoption of the order sets that we had put in place, and there was a fair amount of I will call individualization of the approach to insulin infusions. And so that was just a frank conversation that we had to have, and that we were taking away all of the old and we were going to replace it with just the couple of order sets that we need for endotool, mainly an adult general and an OB power plan, and then some of the other aspects of that care that go along with it. But really it allowed us to simplify and standardize across the system, so that, you know, we feel really good about the fact that now any patient that shows up to any of our facilities in DKA is going to get the same standard of care. And whether you're a provider that goes to one or a couple of our hospitals, or even if we have nurses that go back and forth from one hospital to another, they're able to have a very consistent experience, and that really streamlines how we approach the care. So really dedicating and sticking to your guns as it relates to that concept of standardization across multiple hospitals will pay off in dividends, because now we just have one set of order sets to maintain. We don't have all the different versions that have been out there for a long period of time. It's really removed a lot of clutter from our environment.
Yeah, for sure. And then that's your goal as well, Melissa, as you mentioned earlier on. And then finally, there's a last question is how did anyone quantify the cost of poor glycemic control before you used endotool? I'll ask you that question, Rana, because you sort of been with it the longest across your system. Was there any means to do that?
You know, we've changed a lot over the last 5 years, just in terms of healthcare in general. And until we got on endotool, they didn't really look at the cost of poor glycemic control, because it was just anybody that comes in with a high blood sugar, it's not really that bad. But with CMS and putting out the guidelines that they're trying to have their hospitals get to, and more education about, you know, what is really a good goal for people in hospitals. It was more of a clinical decision a lot of times, like we want to make them clinically okay. Now, as we're expanding our data set at Sharp, we're actually looking at readmissions and length of stay, particularly for your lower than 70 and your higher than 300 blood sugars. So it is going to be a financial gain. We didn't do that before. I'd never had the support to look at those things. Now I've got the support of clinical analytics and the financial teams looking at how can we actually show how glycemic control is actually basically based to a cost and a cost savings in the end.
Bring on more resources for glycemic control in that case.
Yep.
Then it's tough to do.
Exactly.
Well, the hour is upon us, so I want to thank our panelists very much for your expertise and sharing your experiences with us. And just want to, you know, as everyone has mentioned, the cost of poor glycemic control is huge. It's not as well measured as it should be, but we know it's going to increase the length of stay. It's going to increase the cost of care. The one study I mentioned early on, the 20% increase in the cost of care, the cost of nurse burden. So I think there's lots of ways that you can demonstrate a return on investment using a computerized insulin dosing system. And as I mentioned earlier, we do have an ROI tool that we can share with you, that you can calculate savings on your own, that you can contact us and we can walk you through it and answer any further questions that you have. It's a very conservative tool that we've seen to get a lot of good buy-in from CFOs and C-suite. And with that, I will conclude this webinar. And just as a reminder, there will be a recording available for everyone that registered. And once again, thank you, panelists. It's been a good experience. Thank you.
Thank you.